Hello, everyone. My name is Martin Weber. I'm a professor of translational neuroinflammation at the Institute of Neuropathology and the deputy director of the Department of Neurology. When we really think about this question, it's not so much about what immediate treatment do I choose, but what is the sequence of treatments and treatment options that we use throughout the life of a patient. So basically, the idea is to set long-term treatment goals. The question, of course, is how and when each individual DMT is used, when to switch, and of course, including also patient-specific factors such as preference and choice. And then, of course, to integrate these treatment goals in family planning or in older patients, so in other circumstances of their life. So, what are the key considerations for the personalized treatment of MS? Well, first of all, of course, in the events that a patient is faced with, the first is, of course, a diagnosis, and the immediate question thereafter is, what's my prognosis? And we all know that there are a couple of parameters determining what the prognosis will be or looks like. These are biomarkers, clinical features, but also disease subtype, possibly factors of the environment, such as the vitamin D status, for example, MRI measures. So multiple things that needs to be integrated into the understanding and also the projection of the prognosis. And then, of course, probably the most important treatment situation then for personalized treatment is what are the comorbidities? What is this? Let's say the family situation of the patient, pregnancy planning, or having children. Of course, very important patient preference. What are the expectations? And also extremely important, what is the risk tolerance? So one patient is worried about a very effective treatment. The other patient is exactly favoring that one for this efficacy. And then, of course, and this is also a very tricky situation to assess very early or as early as possible in the treatment sequence when to switch therapy. Of course, we look at different situations or different phases in the disease and the different, let's say, options, for example, primary treatment goals and day-to-day treatment goals. Those change also throughout the disease, meaning that when we look at the primary treatment goal, for example, in most patients, of course, is to slow disease progression. Ultimately, disease progression is what it's all about. And managing symptoms naturally is not as important in the beginning, whereas later on, when we look at the day-to-day situation, of course, slowing disease progression is still central, but managing symptoms, for example, becomes more important. So this all needs to be integrated also in the individual situation throughout the disease. Of course, we all want to have the option to treat very early in the disease, particularly as progression in our understanding today occurs very early in the disease, although it, of course, surfaces on the clinical surface, so to say, later on. So is there an option early in the disease to slow disease progression and also, of course, then to prevent a clinical transition towards secondary progression in MS? Of course, it's a shared decision between the healthcare provider and the patient. Very important is to set the goals of the treatment efficacy together. So what's the expected goal? And of course, then again, it is important to keep these considerations in a shared decision throughout the course of the disease in different situations. What are now the clinical targets for patients with MS? Well, we still think that, of course, the ultimate target would be NIDA. The goal here is no evidence of disease activity. It's a little bit a, let's say, well-used term, which I believe is a little bit overstating that we really silence all aspects of MS. I'm not sure, or I'm not so sure anymore whether that's really possible. What is meant is that the patient is not undergoing clinical relapses, of course, that there's no MRI dynamic, so no gadolinium-enhancing lesion, but also no active T2 lesion. And ultimately, of course, that there's also no confirmed disability progression. To date, these treatment goals can be best achieved by starting early with treatment in a patient with relapsing remitting MS. And we know that if we treat early, then we can probably at least downplay the ultimate accumulating disability in a certain extent. So basically, the early treatment determines what's happening later on. This is still the case since we are only able to treat the highly inflammatory part of multiple sclerosis. So I think the early window of opportunity, which is still valid, that term is still valid, also refers to the fact that we don't have so efficient late-stage treatments. So, for example, treatments that really reach into the central nervous system, where probably most part of progression happens and occurs. So, still, as it is as of now, we believe an early window of opportunity is best probably to achieve the treatment goal of NIDA. This is something that also refers a lot to experience. So I think we all need to see a lot of patients to get a feel for that. But there are, of course, also factors, key factors that needs to be taken into consideration to assess exactly that point. And there are a couple of biomarkers that, of course, can, on the one hand, project a little bit the disease course. But it's, of course, also important that the efficacy of available DMTs match more or less this activity or the disease activity which we think is appropriate for the individual patient. So what are the factors associated with poor outcomes in MS? A lot of these factors, unfortunately, are best described later on in the disease. So basically what we, of course, all look for is an early biomarker which can tell us that this patient needs to be treated differently and possibly also more aggressively. What we still think which is associated with a poor outcome in MS is older age at onset, then also male gender. Of course, comorbidities, both cardiovascular and psychiatric, and smoking. So one factor at least that we can change in our lifestyle. Then, of course, the disease-related clinical features. So how does MS occur in the individual patient? Number of relapses, of course, more relapses, more disability, poor recovery from relapses, or including the first relapse. So even after the first relapse, you can project, at least in part, a little bit what the next relapse and particularly recovery from the next relapse will look like. And then, of course, the occurrence of symptoms. So cerebellar cognitive symptoms at onset, clinical presentation, that, of course, all basically influence what the outcome is ultimately. And progression onset, I think that's relatively clear. Progression and sometimes poor recovery is really hard to distinguish, at least in the beginning of the disease. But of course, they both factor in when it comes to disability accumulation. Then MRI features a lot of lesions, and lesion dynamic over time is, of course, associated with a poor prognosis. Infratemporal lesions at baseline spinal cord, both for the reasons that they are very highly clinically relevant, of course. And then also the, let's say, localization within, for example, the cortex of the lesions is important. And, well, probably also measures in the laboratory. I think that would be particularly helpful, as we can, of course, recover these from the very beginning. And the presence of OCBs, oligonucleotide bands, are associated with poor outcome. Well, there is, let's say, not too dense information on direct comparisons of therapies, but we get an idea with few clinical trials with comparator therapy. I think what's helpful is long-term open-label extension studies, where we can really see the real-world evidence that these medications change the outcome of the disease. So these are, I think, the most helpful information to assess or to compare directly what we think is a high or medium efficacy DMT for relapsing MS. And then, of course, the question is always where is the cutoff between high efficacy and medium efficacy? A lot of the newer monoclonal antibodies should be considered clearly as high efficacy DMTs. What's a little bit problematic is that this is assessed basically on the MRI efficacy and not so much on the ultimate outcome, which probably we'll know in a couple of years. Hello, everyone. My name is Martin Weber. I'm a professor of translational neuroinflammation at the Institute of Neuropathology and the deputy director of the Department of Neurology. I think that's a key question to understand whether B cells truly contribute to progression independent of the individual relapse. So, of course, we need to think of pro-inflammatory cytokines provided by B cells. We also need to take into consideration the great ability of memory B cells to probably act as antigen-presenting cells, but also as activators for other immune cells. Regulatory B cells, on the other hand, that could downplay inflammation going on in the central nervous system. And then, of course, the possibility that B cells play a differing role in the CNS versus the periphery, and of course that impacts where and how to target B cells with, for example, anti-CD20s, but also other therapies. So when we look at the role of B cells in the pathophysiology of multiple sclerosis, there is by now multiple roles that needs to be taken into consideration. One is, and I think that's probably already the most important one, the interaction with other immune cells, so providers of cytokines, as just mentioned, both pro-inflammatories, such as IL-6, for example, but also anti-inflammatories, such as IL-10. The ability of B cells, particularly when they recognize via their BCR the antigen to be presented, to act as antigen-presenting cells for T cells, so to generate T effector cells. Then, of course, there is regulatory B cells, possibly also a regulatory B cell dysfunction or disbalance in multiple sclerosis. We know probably best, or for the longest time, that B cells differentiate into plasma cells, providing oligonucleotide IgG, still important for the diagnosis of multiple sclerosis, and then particularly important for the part on progression, that B cells interplay with CNS resident cells, such as microglia, astrocytes, again, probably most importantly in a pro-inflammatory manner, but possibly also in a regulatory manner, particularly providing IL-10. I think there's pretty strong evidence for this particular mode of action. We have now decades of data on rituximab, ocrelizumab, ofatumumab, and lastly now on ublituximab collectively. So if we combine these data as anti-CD20 drugs, then we have very well experienced, let's say, approach to target B cells. And then the other question is, and that of course refers to the question of CD20, what is how do they differ, these drugs, from other DMTs? Well, first of all, it's important that, of course, we are targeting with these drugs CD20 carrying B cells. And one question is, and that question could be answered throughout the last years, that this includes also a small fraction of T cells, the T cells that are CD20, and very strikingly and interestingly, these T cells, they get CD20 from a B cell during activation, so during APC T cell interaction. And that means that CD20 and anti-CD20 depletes a fraction of recently B cell activated T cells. And that, of course, could be extremely important for the efficacy of these treatments, both in the periphery, but also in the central nervous system. And then the second point, of course, is that I just referred to these drugs as the class of anti-CD20 antibodies. That is true, but of course, there's also differences between rituximab, ocrelizumab, ofatumumab, and ublituximab, particularly when it comes to the part, or the, let's say, percentage of the antibody being human, which underwent a little bit of an evolution, so to say. When we then look at the key efficacy data, I think it's pretty clear that all of these 4 different drugs are extremely efficient when it comes to silencing MRI activity and also preventing clinical relapses. I mean, there's almost a virtual absence of clinical relapses with these drugs. But of course, the open question, or the, let's say, less or we have less information on that question, is whether they truly also are efficient within the central nervous system, and whether they really can slow down progression independent of relapses. And to be honest, I think that question is still open, and is not so easy to answer, also from a trial perspective. So how to design these trials and so on. Then, of course, the ultimate question always in medicine is, what's the disadvantage? So what are the adverse events? And in my mind, relatively surprisingly, the adverse events are not severe. Surprising, since in the beginning I thought that B cells, CD20 positive B cells, are needed, and I think the recent pandemic showed us that of course we need an effective immune system and a response. But due to the fact that the plasma cells are not depleted, we can probably, at least for some years, we can easily, or relatively easily, live without B cells. And most of the side effects are both on the infectious side, but also on other parameters, are very relatively light when it comes to the efficacy of these drugs. Well, I think what needs to be discussed here is, of course, the long-term safety considerations. So what I just said about the plasma cells not being depleted also needs to be some information added here. Then, of course, plasma cells cannot generate plasma cells, so they are generated from B cell precursors. And that means that ultimately, of course, the plasma cell pool will be also depleted, or at least reduced in numbers. And so we need to really long-term assess the safety of this approach, including the checking or constant checking on the Ig levels, which at least in some circumstances seem to lower with continuous anti-CD20 treatment. And then, of course, the question here is always what other parts of the immune system are missing when it comes to adverse events, and what needs to be taken in consideration. Also, of course, I think in long-term observations are particularly, as I already said, the drop in immunoglobulins, infections, and neoplasms, because I think also a very low frequent, by itself already low frequency neoplasm can be easily overlooked. And so, of course, we need to be particularly careful when it comes to changing parts of the immune system that the fight against cancer cells is not impaired. It's a relatively difficult question, I find, for myself, because there's not such a thing as a B cell MS marker. But I think, of course, when we look at what these drugs can do, a very MRI active patient, for example, of course, is already somehow a good patient for anti-CD20. Then, of course, we possibly can look at CSF biomarkers, and what we said earlier, I think is extremely important. What's the risk, or what risk is the patient willing to undergo? I think that's important points for the question who should be treated with anti-CD20. Hello, everyone. My name is Martin Weber. I'm a professor of translational neuroinflammation at the Institute of Neuropathology and the deputy director of the Department of Neurology. Here, I think we have basically to look, of course, at anti-CD20, but more now in comparison to other available B-cell directed therapies, such as BTK inhibitors. And BTK inhibitors, it's Bruton's tyrosine kinase inhibitors, are, of course, or need to be differentiated from anti-CD20s, and they work very, very differently, although they both target B cells. So very exciting that we now have, with these BTK inhibitors, the novel approach towards targeting B cells that is not depleting B cells. So where could BTK be important? Well, BTK is the enzyme that is centrally involved when a B cell is activated via its BCR. So it's the BCR on the surface, and right under the surface is Bruton's tyrosine kinase, in short, BTK. And then, of course, we have multiple sites throughout the pathogenesis of multiple sclerosis where this particular B cell activation could be important. And I think it naturally already in the periphery limits a B cell activation, of course, downstream of the BCR. And that also includes, or that thinking includes, that a B cell is not stimulated in an antigen-specific manner, which also means that antigen-specific B cells cannot proliferate and differentiate into plasma cells providing antibodies. So you're starting B cell activation very early in the cascade of B cell properties contributing to disease. And then the other opposing, so to say, question or possible mode of action is BTK activation is most likely needed when B cells form into in the CNS in secondary B cell follicles. And these B cells most likely also interact, as we learned earlier, with CNS resident cells such as microglia and astrocytes. And if you inhibit, or if we would possibly inhibit B cell activation via BTK inhibition in B cells within the central nervous system, then basically this constant activation of microglia and possibly also the differentiation into plasma cells providing oligoclonal bands could be inhibited. So there's great hope that these drugs, which are small molecules, also make it into the central nervous system, and they, of course, then B cells could be most likely better be targeted than with anti-CD20. And if B cell activation could be reduced, these drugs could really make a difference when it comes to slowing down disease progression independent of relapses. So the, I guess, ultimate treatment question right now in the field of MS therapies. So these are the three agents being in development where we already have efficacy data, most of it phase 2, phase 2B data. And it's very interesting because these trials, they differ in parts, particularly when it comes to the secondary outcomes. And so we obtain from each individual trial, we obtain other parts of information. And of course, the most important, as I already said, the most important question is whether these drugs act in the central nervous system, and related to that question, whether they can slow down progression by its central activity. That would be, of course, great. We have an idea by now that all of these drugs, or this new, let's say, kind of drug, in clinical trials generate some side effects. Most of them are manageable. We see a couple of serious adverse events reported in clinical trials, and most of them, interestingly, and that of course differs now from the anti-CD20s, most of it, at least with the data that we have, refer also to liver abnormalities, so liver enzyme elevations. So again, of course, these small drugs are more likely to also interact with metabolic parameters in the body. And besides those, and that's of course always the fear when it comes to treating MS, it's of course the infectious stuff that we usually see, so nasopharyngitis, not very severe signals, but of course signals that we need to carefully watch throughout the next years. So I think that's, of course, always a very important information to see where the limitations of the information also is, and how might this impact patient selection? Well, I think it's a relatively, let's say, important question, but very early, of course, in development. Not so easy to assess and answer at this point, I would say. Well, we can, of course, from different trials, see, for example, fenobarbital being trialed in progressive MS, that we, of course, get an idea which niche these drugs later on could be taking, or what the respective companies, let's say, idea is where to put them. But I think that's it's relatively early, as I already said, to really provide an answer to that based on phase 2 data. That's not so easy. That is not so easy to generate, or this information is not so easy to generate from the individual clinical trials, because of course you will always see a relative efficacy in terms of controlling parameters of NIDA, so particularly MRI activity. And it could be that we need to be a little bit more intelligent or more smart for this kind of drugs than we usually do in these trials. So for example, it could be a very nice approach. BTK inhibition could be a very nice approach to be implemented after anti-CD20 B cell therapy. So we have emerging data from our lab that the B cells regrow in a non-pathogenic manner when the BTK inhibition is placed as a maintenance therapy. So it could be that that there is a certain sequence of B cell directed therapies which then benefit best, or provides the best benefit for the patient, both in terms of eradicating pathogenic B cells at the very beginning and then regrowing not so pathogenic, hopefully regulatory B cell properties when we implement BTK inhibition as a maintenance therapy. And that's it, exactly the let's say the problem that we have, that at least when we look at the different drugs that are implemented throughout the disease course, so to say, so CIS, relapsing MS, and then SPMS, we are often comparing things head to head, which need to be thought in sequence. So what I think is or should be thought of with these drugs for the very beginning is not so much, so where do I put them immediately? So which patient should be treated with this kind of drugs, but more to place them into its sequence. And I think, again, as I already said, I think these are extremely attractive maintenance therapies, since they control B cell activation without the necessity to deplete B cells, which I think is the ultimate gain from this kind of drugs.